Hello, all, and welcome to another episode of Discussions with Dr. G. Let's get one thing straight right out of the gate. Nutrition isn't just about eating leafy greens and pretending like you like quinoa. I swear, if I had $1 for every nursing student who's told me, but Dr. G, isn't nutrition just like eating salad and maybe drinking less soda? I could retire and buy a small castle for my cats. The reality? Nutrition is absolutely clinical. It's foundational, not decorative. It's as crucial to healing as antibiotics or a well-placed IV line. Good nutrition underpins growth, supports the immune system, keeps healing on track, and here's the kicker, plays a huge role in preventing those chronic headaches we see every single shift. I'm talking obesity, cardiovascular disease, type 2 diabetes. Prevention by nutrition is, let's face it, way less work for everyone than chasing after complications once they've landed. You also can't treat nutrition like it's a one-size-fits-all handout stapled to discharge papers. Nurses are the boots on the ground for spotting nutrition risks. This means you're assessing not just what the client eats, but how disease, their social situation, cultural background, heck, even their zip code, impact what ends up on their plate. Bottom line, if you think nutrition is a lifestyle thing, think again and grab your stethoscope because you're already in the game. So, speaking of risk, let's talk malnutrition. And yes, that's not only a late night infomercial problem. There are 3 buckets here, according to the WHO. First, undernutrition, your classic not enough calories or protein, which shows up as low weight for age or height. With these folks, you get muscle wasting, anemia, poor wound healing, basically the human equivalent of a weak Wi-Fi signal. Nothing works right. Then there's the sneaky beast, micronutrient imbalance. Too little or too much of things like vitamin D, iron, or even selenium, and you're staring down a laundry list of problems, from nerve issues to organ dysfunction. Last up, overnutrition. And yes, that is a form of malnutrition. We see this in obesity, and it comes with higher risk of type 2 diabetes and heart disease. For nurses, that means early screening is everything. Pay attention to weight trends, track what goes in and what comes out of, and please don't ignore those small cues that someone's nutrition is off. This is more than a number on a scale. It's about safety. Malnutrition ties right into poor healing, falls, even greater infection risk. Catch it early and you can change the game for your patient and avoid some serious headaches for yourself. Now, let's dig into what actually matters at the bedside. Macronutrients, micronutrients, and please don't forget water. Carbs get trashed a lot in the press, but they are literally fuel. You need them for energy, sure, but they're also friends to your immune and GI system. Think grains, beans, fruit, milk. Protein. Now we're talking tissue repair, immune clotting, you name it. Animal or plant, you need the amino acids, especially if your patient's got wounds or just had surgery. Then there's fat. This is your calorie powerhouse, essential for structure, growth, insulation. Don't let anyone tell you the body runs on empty. It doesn't. Under micronutrients, you've got vitamins, B complex, C, A, D, E, K, all the crucial players. And then you have minerals like calcium, iron, zinc, all those hard to pronounce elements. Electrolytes too, sodium, potassium chloride, magnesium. These keep the lights on, electrically speaking. And finally, our silent hero, water. Total body water is high at birth, around 80%, but that drops as we get older, and it splits about 2/3 inside the cells and 1/3 out. Regulation? That's a beautiful dance of osmoreceptors, thirst, and oh, I always mix up this acronym, ADH. That's anti-diuretic hormone. Bottom line, check your patient's intake. Small changes get big fast. Now, let's stay on the water train for just a moment. I got to highlight dehydration because honestly, this is one of those high yield nursing concerns that just keeps showing up. Older adults are at huge risk, whether it's because they can't get to the kitchen, their meds, meaning mess with their thirst, or they have type 2 diabetes and or kidney disease, loving to complicate things. But dehydration isn't just a little dry mouth issue. It can spiral into hypotension, kidney failure, electrolyte messes. Don't panic because death, if ignored, can happen if this goes on long enough. I'll never forget this elderly gentleman who was sent up to our floor from the ER totally confused, and everyone starts working up on a stroke. Turns out, poor guy was simply bone dry. A couple of liters of fluid, and his brain was back online. I'm telling you, check for subtle signs: sudden confusion, low blood pressure, dry mucous membranes, poor skin turgor, even falls. Everyone thinks it's delirium. Sometimes it's just dehydration. Make hydration checks a non-negotiable habit, especially in your older, sick, or immobile patients. Now, let's pivot to what you actually tell patients about eating. A lot harder than it sounds, trust me. I like to start with my plate, the updated version of the old food pyramid. It's super visual. Half your plate is fruits and veggies. About a quarter of your plate is whole grains. And the other quarter is low-fat protein. And don't forget your dairy. Guidance: try for nutrient-dense foods about 85% of the times, with fats and sugars making up that difference. Low-fat or fat-free doesn't mean no flavor. It means more risk reduction for stuff like diabetes and heart disease. There is a catch. You've got to tailor the message. Preferences, culture, what people can actually afford. These are all critical points. Then you've got your named diets: Mediterranean diet, DASH diet, MIND diet. Mediterranean is all about plants, olive oil, fish, fruit, and just a splash of wine. Not bad, right? Smooths out inflammation, lowers cardiometabolic risk. Then you have the DASH diet, which focuses hard on low sodium, which is great for folks with blood pressure or kidney issues. The MIND diet is basically a brain health remix of the other two. Think more leafy greens, berries, nuts, olive oil, and fish with less butter, cheese, and red meat. But again, you've got to adapt the message. Not everyone grew up eating Greek salads, so swap in foods that make sense for your patient. All right, special consideration time, because there isn't a single nutrition rule that fits everyone, especially if you factor in age or illness. For infants, it's exclusive breast milk until about 6 months, or iron-fortified formula if needed. Don't skip that vitamin D supplement. Then, starting solids at about 6 months means mixing in iron and zinc, like those fortified grains everyone ignores. By the time you hit 12 months and up, you're in the nutrient-dense everything club: veggies, fruits, whole grains, protein, healthy oils, yada yada. Pregnancy and lactation need more calcium, iron, folate, vitamin D, protein, zinc, and oh yeah, omega-3s. For aging adults, keep an eye on calories, protein, and hydration. Hypermetabolic states, think severe burns, major illness, or even hyperthyroidism. These crank the body's energy use way up. Suddenly your patient needs a whole lot more nutrition, sometimes via feeding tubes or TPN, that's total parenteral nutrition, literal IV calories, vitamins, and minerals. Oh, and a quick point: anorexia is just low appetite, while anorexia nervosa is a psychiatric diagnosis. Totally different animals, by the way. BMI and waist circumference are just screenings, not a diagnosis. Remember to account for things like age, muscle mass, and cultural context. So, how does this all look when you're alone on the floor and your preceptor's busy charting in the lounge? Here's your practice-ready checklist. First off, monitor weight trends, daily intakes, and hydration signs, especially in anyone who's older, confused, or suddenly weak. Track BMI and waist, but remember, they're just a starting point. Next, you want to watch lipid and glucose labs. That's your HDL, LDL, triglycerides, glucose, and HbA1c. Use those as coaching points. Teaching? Yeah, that's on you. How to read a food label, swapping saturated fats for unsaturated fats, cutting added sugars, boosting fiber, and suggesting food swaps that are both realistic and culturally acceptable. Escalate care if you're worried about malnutrition, burns, or patients who just can't meet the needs by mouth. That's when you call in the dietitian or consider nutrition support like tube feedings or TPN. Always screen for barriers. That's going to include cost, transportation, literacy, and culture so that your plans actually work outside the hospital. All right, that's it for this round. Keep those nutrition goggles on, and next time we'll dive deeper into real-world nursing tips that you can use before you even finish your coffee. See you then.